Hello, I'm Dr. Terry Box. I am an associate professor of medicine at the University of Utah School of Medicine. It's my pleasure to talk to you today and address some of the questions that come up when I talk to my fellow colleagues or make presentations about hepatorenal syndrome. Before we really jump into the first question, I thought that perhaps just a little introduction to the relatively recently changed nomenclature and definition of hepatorenal syndrome would be useful to this discussion. We used to talk about hepatorenal syndrome type 1, hepatorenal syndrome type 2. Type 1 was that very, very morbid and frequently fatal acute and rapid onset of renal insufficiency associated with cirrhosis and ascites. Hepatorenal syndrome type 2 was a slower developing thing that typically was not quite so morbid and occurred over several weeks to months. We no longer talk about hepatorenal syndrome types 1 and 2. We talk about hepatorenal syndrome acute kidney injury, or AKI, and hepatorenal syndrome non-acute kidney injury. Still, for the most part, our biggest concern would be the more acute AKI, HRS-AKI. In the old days, we defined type 1 HRS as requiring a creatinine of equal to or greater than 2.5 milligrams per deciliter occurring over a 2-week period. Our definition is entirely different now, such that HRS-AKI is defined as at least a 0.3 milligrams per deciliter increase in serum creatinine over a 48-hour period. Now, frequently, we don't have that baseline 48 hours ago. We can go back as far as 3 months, and if the bump in creatinine is at least 50%, 1.5 times baseline during the last 3 months, we define that as HRS-AKI in the setting of cirrhosis and ascites, assuming there are no mitigating features such as infection, use of nephrotoxic agents, and there is no response to volume and colloid replacement. In other words, after a 2-day challenge of fluid and albumin, the change in creatinine persists or gets worse. That is HRS-AKI. That brings us to the first question. With that new definition, does that mean that HRS-AKI occurs in the setting of a normal creatinine? And the answer to that question is yes. And when you think about our patients with advanced liver disease, advanced cirrhosis, large, taut abdomen filled with acidic fluid, frequently requiring multiple episodes of large volume paracentesis, think about how they otherwise look. Almost always, they have skinny arms and skinny legs. They've lost their muscle mass. You can see their ribs. They've lost muscle everywhere. When you think about serum creatinine, it comes from muscle turnover. If you don't have muscle, you don't have much serum creatinine. So the answer is yes, you can have a serum creatinine that goes from 0.8 to 1.2 over a 48-hour or 3-month interval, quite frankly. It's normal. It's less than 1.5 milligrams per deciliter, but by our definition, no volume response, get rid of all the mitigating features in a patient with cirrhosis and ascites, that by definition is HRS-AKI.